let everybody else trickle in. So I want to thank you all for being here today. We really appreciate you participating and taking time out of your busy schedules. I want to thank Shelby and John for being here today to talk about health inequity and our current circumstances with COVID and everything going on. So we do have some learning objectives for today, but as it were, we do want to focus on making this as discussion-based as possible. And making sure that, today you walk away with a better understanding of how inequity creates, the conditions for infectious disease spread, how Corona is affecting existing health inequities, and how health, outcomes are being affected by this. And lastly, we do want to make sure that this is a forwardly focused discussion. So we are going to be concentrating on some of the potential impact areas and actionable items that we can all take to mitigate some of the effects of the virus on health inequity. So a couple housekeeping kind of things. If you come in or if at any point there's some background noise, if you could just keep yourself muted. And I do want to point out the chat feature in WebEx. If you have any questions during any point of the conversation, feel free to type them into the chat. We're going to be collecting those and then saving time at the end to get through as many of those as possible. And we are also going to be recording this for anyone that is interested or wasn't able to make it during the live viewing. So if you have any questions, feel free to pop them in the chat. And again, I just want to thank you all for being here, and to Shelby and John for joining us today. So if you are not familiar with our organizations, I know we have a wide range of attendees from in-state, out-of-state. So if you are not familiar, Shelby and I, my name is Emily, by the way, that's probably important. We both work at Healthy Capital District Initiative, and that is a nonprofit over in Albany, New York. And we are kind of dual-rolled in our purpose. Half of the organization seeks to provide health insurance enrollment. They work with community members to get them, connected with the social services that they would need. Then on the other side is more of our population health improvement program, the public health work that we do, where Shelby and I work. We work with local stakeholders, data partners. We produce many data products and work with other local community-based organizations to build capacity within the community. So as I mentioned, our speakers, Shelby and John, are going to be joining us today. And Shelby, I'm very young, is a social epidemiologist who specializes in the contribution of social determinants of health on chronic disease. She had the privilege of receiving the Michael Marmot studentship during her study at the Institute of Health Equity in London. She is the current public health planner for Albany and Rensselaer counties at HCDI, in addition to managing our community health network, which we're happy to share more about. So if you haven't heard of Phenomics, it's a very interesting company, and it's a technology that leverages rapid MRI and rapid CT scans, as well as patient triage artificial intelligence data. And they do this to measure organ-specific or whole body phenotypic changes to an individual. And this technology enables risk stratifying patients, populations, down to the zip code level. And they use this to potentially mitigate some of the effects that inequity has in healthcare and health outcomes. Phenomics services fit within a value-based care model. They provide a quantitative tool to measure the impact of SDOH, and ultimately they seek to usher in a new era of personalized healthcare. So John, who is the Vice President of Business Development and Social Determinants of Health Strategy, he is responsible for building collaborative efforts and partnerships with hospitals, health systems, payer organizations, and other governing bodies in North America. John also just developed the Phenomics recent COVID-19 PPE and test kit US supply chain and sales and marketing efforts. So really interesting stuff. I'm going to stop talking now. I want to just jump right into this and let these guys tell you all that they know. So I want to just start off by, diving right in there and asking, we're seeing a lot of the poorer or lower income regions in New York City being hit much harder by coronavirus than some of the other neighborhoods in that region. So to bring it home, do you think that we can expect to see the same thing in upstate New York? And what can we do about this?
I think, I think we already are starting to see that same trend up here. As you kind of mentioned in the objectives, inequity creates the conditions that enhance the spread of infectious disease. Infectious diseases, they cluster. We see this on like smaller scales in like a nursing home or a jail or a homeless shelter. But it's for a lot of those same reasons why infectious diseases also cluster around the poverty-stricken communities as well.
Yeah, so I want to just echo back to something that you just mentioned about how, like this could be a breeding ground in poverty-stricken communities. So what are the factors that are leading to this? Is it a lack of social distancing, or, what do you think that we're seeing this for?
That's definitely part of it. Social distancing is really not as feasible for lower income communities. Many of the essential workers that are continuing to work, they often don't have paid sick time. And this can have disastrous consequences. Influenza research every year shows us that areas of poverty have higher transmission, they have higher mortality rates. In fact, during the H1N1 outbreak, 27% of the entire outbreak was attributed to 30% of people who continued to work while exhibiting symptoms because they didn't have sick leave. So we can see how much of an effect that not having sick leave can have on infectious diseases. Also, individuals of lower income communities, they tend to live with more people in multi-unit housing, smaller living spaces, poor air quality, asbestos, mold. I mean, these are type of the conditions that we are seeing people live in. And, they don't have space to even separate the living from the well. So you can't even really social distance within yourself, in your own household, if somebody is sick. I think also too important to mention is another reason why lower income communities are hit harder has to do with a lack of understanding of how to even protect oneself in those communities. Easy behaviors and recommendations, they really aren't easy for all of us. And some communities just seem to be left out of the loop. Some people, they don't have internet, or they barely have the time to keep up with the news and all the changing recommendations. Many people, they don't even know where to go to get that information, and they don't understand it. They don't know how to wear PPE, let alone to make it. So these are all definitely some of the factors that are contributing to this.
Yeah, so I think you're bringing up a really important point, or highlighting the difference between the ways in which, the professional sector, or people that do have paid time off, and those who don't, are able to respond to the virus. So do you or John want to jump in and kind of let us know, like, what can be done, or how can we help these, these groups that are experiencing these differences?
I'll start by saying we have a tremendous opportunity, clearly, as a result of the efforts that have taken place under the auspices of social determinants of health and addressing social determinants of health. So there are community-based organizations who are structured and geared towards these particular challenges. So I would say on a local level, within our at-risk communities, where we're seeing the highest prevalence of inequity, we have the opportunity to collaborate with our hospitals and health systems at point of discharge, so we can begin to identify those patients who have a propensity of having a less than favorable outcome because of the condition or environment they're in, notwithstanding challenges as they pertain to health literacy or health numeracy, excuse me. So those are some of the things that we can begin to do. In addition to that, we have to rethink, how we are going about the healthcare communications process. There's a gap there that needs to be filled, because not every patient can comprehend the communication of a provider. Not every provider, healthcare that is, can fully grasp where that patient is coming from. It's not intentional. It's just the nature of things. So the more intentional we are about that, and going about mitigating this, which is possible, the better off the outcome will be, and the better off the patient ultimately would be as well, notwithstanding the healthcare delivery system.
Yeah,
So those
absolutely. Yeah, and I'm glad that you mention it as being, this opportunity for us to address some of these issues, because obviously these health inequities were existing before, and now we're seeing obviously current times exacerbating that. So we know that these communities are having higher transmission and mortality rates, and like you were saying, this isn't always intentional, like the pitfalls, but I would be remiss if we didn't talk about the economic effects and how potentially economics comes into play with all of this.
That too is a great question. I think to fully grasp the economic picture, we have to take a step back. First, we have to realize, notwithstanding, government intervention today to get us through this very difficult time, we've always had a snapshot of the impact of health economics on economy. Everyone is very much aware of that are in the healthcare space. When one looks at GDP, if you would, healthcare GDP historically, you could see that we were approaching 20% at one point, which is not a number to be proud of. And so in the wake of that, there's been opportunities where through, for example, CMS, that has identified over $17 billion per annual that could be mitigated by way of, or mitigated in part, I should say, by way of addressing social determinants of health, which is to say, those patients that would find themselves returning back to a hospital subsequent to discharge, not for clinical needs, but for those social needs to be addressed. So there we have an opportunity to reduce costs. And so naturally, in mitigating, those avoidable costs, clearly there's an opportunity to redirect funding. The other piece, what I think is certainly relevant here, in 2009, the Johns Hopkins University, in conjunction with the University of Maryland School of Public Health, had released a study, the economic burden of healthcare disparity or healthcare inequity. And what they had discerned is that over a year period, over $200 billion are lost to healthcare, are lost to the US government as a result of not addressing the healthcare inequity challenge or opportunity that we have. Likewise, if you were to extrapolate that, and again, I'm paraphrasing from the study, but likewise, if you were to extrapolate from that study over a 3-year period, there was a $1.24 trillion erosion, if you would, of revenue and earning potential across the market. So we have a tremendous opportunity by being more intentional in terms of how we address healthcare inequity. And again, one can only begin to imagine what can be done if we were able to go back in time, which we cannot do, and look at this again more intentionally in terms of the opportunity that we have and redistribute, if you would, that would be areas by addressing these challenges. Just imagine, what may have been. Perhaps it's very likely, that the issues that we're seeing in terms of inequity, disproportionately we're seeing among Latino Americans and Black Americans, it could very well have been mitigated years ago. But again, in the spirit of being forwardly focused, embrace this, recognize where we are, and we can go forward from an economics perspective to make a tremendous impact. And then the last point I want to make, and this underscores the challenge and opportunity, an estimated 12% of our population is essentially linked directly to over 40% of overall US healthcare expenditures. So clearly we have an opportunity, and this is something that should have been clear from the outset of our challenge, that if we redirect our focus to these at-risk communities more intentionally, more timely, we have a tremendous opportunity to go upstream and begin to intervene and circumvent many of the challenges that we're seeing today. So those are some of the points from an economic perspective that we should certainly be leaning into and have the opportunity to make a difference within.
Absolutely, those are some incredibly important points. And I want to point out that a member in the chat had mentioned, collaborating with CBOs in our neighborhoods and elsewhere as a really important opportunity. And I do think that we are seeing that on our local level. I mean, I'm sure that's happening on a national level as well, but using those really important and connected community-based organizations to leverage some of that, the position that they hold within the community. So great opportunity.
I think too, when we talk about economics, there's kind of two sides to this. There's the overall economy and the healthcare economic side, and then there's also like what's happening on an individual level. I think that we're going to see from the economic effects of this shutdown, we're going to see higher rates of chronic disease in the future. And these sort of things happen because poverty in and of itself is an underlying health issue. We're actually working on a report here at HCDI on that, showcasing that very thing. But essentially, poverty creates a set of overwhelming circumstances which deprive people of basic necessities and creates an incredible amount of stress. This ultimately leads to a decrease in the length and quality of life. And this is why we see higher rates of chronic disease in lower income communities. I think also a Federal Reserve study last year said that 4 in 10 workers would struggle to find $400 in an emergency. I mean, that's with them working. And also at the end of March, the last week of March here in the capital region, we had over 2,700% increase in unemployment claims compared to last year. So, I mean, this is going to have a disastrous effect on future chronic disease.
I did see a tremendously overwhelming response to all those unemployment claims, and just so many organizations, I mean our own, but so many in the community just really trying to band together and get people connected with the services that they need. So I do think that on a local level things are starting to kick in as we recognize many of those points that you're bringing up, Shelby, and the effects that this could have, just people banding together and trying to get our community members connected. So you bring up, how stress and, these overwhelming circumstances can lead to a decreased quality of life and overall lifespan. So I want to just touch upon, social isolation and how this can affect our population's mental health now that we are officially, social distancing.
I don't think enough can be said about this challenge. It's clearly we're seeing the evidence of this particular aspect of isolation to the at-risk communities, but we have to, not lose sight of, the adverse child experience phenomenon. This is very real. Our youth, ranging from adolescents, pediatric patients, if you would, as well, they're exposed to what would be deemed a toxic environment in the midst of all of what's going on, the uncertainty, their inability to grasp the complexity of a COVID-19 and its impact. And so, again, when we look at the ACE study, one of the things that we know for sure is that the toxic environment, this impact that it has on our youth long term, should be of concern, and it should be something that we should be, again, intentionally focusing on, because the reality is that this toxic environment phenomenon is a direct influence to later in life chronic diseases such as heart disease, such as obesity, diabetes. There have been direct links to ACE and these future outcomes. So we have to be more intentional and think about this from a long-term perspective. Clearly, there are opportunities through the advancements of artificial intelligence and technology to rethink how we go about the physical exam, where we can begin to monitor these very changes early on in life throughout the continuum of one's life because of the non-invasive component of these technologies that allow one to look at changes at the biomarker level well before a chronic disease presents, but with enough time and evidence to look at how can we rechart community so that we can circumvent the challenges that we would be faced with, not only from the standpoint of the patient's experience, but as well as the economic outcome and total cost of care.
Yeah, absolutely. Shelby, you want to jump in? I know you definitely care deeply about this issue, and I'm glad, John, that you bring up the point about children's mental health, because I think that oftentimes that is a demographic that gets left out of the conversation when we're talking about mental health and those effects. So I'm really glad that you brought that point up.
Yeah, I agree. I think children are an extremely susceptible group right now. School, with that routine, without that, many children are going to take on the anxiety of the world that they see around them. And as John mentioned, we see from ACE's research the disastrous effect that childhood trauma can have on later stages of life. This has been studied over and over again, and it's basically been associated with almost every chronic disease you can think of. Plus, added onto that, the stigma that surrounds mental health, and especially with children and parents not knowing where and how to get care. I mean, this is definitely something that's of concern, and I think that it's also an opportunity for impact as well, because we can really spread the resources that are out there and really help to try to reduce that stigma. That is something that we can do and share with parents all of the resources that we have existing in the community.
Yeah, so I want to hunker down on this just a little bit. So obviously schools are closed down right now, and those are, those spaces are incredibly important buffers against some of the negative effects that SDOHs can have on children. So what can be done? I mean, I know, John, we had spoken about a mentorship program that you had put together. So can you guys tell us a little bit about what can be done in the midst of all of that?
Yes, absolutely. As a point of reference, to your point, the mentorship program, which I was so honored to be a part of and to collaborate with over 35 plus professionals in the Capital District, serving a school in the Schenectady School District for nearly 4 years. And, we often think about, okay, yes, something has to be done. We have to address social determinants of health, but not everything that has to be done and can be done is associated with a cost. So that particular program, what was really unique about it is we had a plethora of professionals that would come in under the auspices of speaking to one's passion and vision and why they did the work that they did and what was the impact of the work that they did, not only on their lives, but on the lives of others. And that messaging resonated profoundly for the students as well as the teachers that were part of that program. So the point there is we can do more. And again, even with our schools closed, we have an opportunity to reach out to the schools, and we can through Zoom for those who are not overly disconnected due to a lack of digital access, but to those who have some access, even if it's on the phone, we can begin to mentor and collaborate and really leverage technology to its fullest. So those are some of the things that we can do. But again, in that same vein, enough cannot be said about the digital divide. This is a very real phenomenon. And when you think about those students that are in the midst of this challenge and are at risk, underserved communities, they are the ones that are really getting the short end of the stick here. They're not able to maximize the virtual education environment as others are who are in more affluent environments. So certainly something we need to dig into a little bit deeper and look at alternate ways of moving the needle forward so that we can circumvent and mitigate that crisis and challenge as well.
Absolutely. Shelby, you want to jump in?
Yeah. So when it comes to homeschooling, not everybody has the capacity to do that. I have firsthand knowledge of this because my sister has a learning disability, and to an outsider she might seem fine, but her reading level is in the elementary school level, and she has a 5-year-old child who relied on Head Start to teach. She essentially went from working and earning money to being an unpaid full-time mom/teacher. She doesn't have the capacity or the time or the knowledge to even do that. She has no idea where to start. She doesn't have internet. She doesn't have a computer. These are very real problems. And I think the bottom line, is that most kids are going to turn out fine. Their parents will pick up the slack. Technology will pick up the slack. But it's for those individuals who were already worse off and whose children were already behind. these individuals are going to fall even further behind. And, all of this impacts health because without a good educational foundation, life is like climbing Mount Everest without any equipment. And that stress takes a toll on the body. Also, students with disabilities, that's another concern of mine for sure. The structure that school provides, it can be very important for students with disabilities and students on the spectrum as well. In New York State, we have over 500,000 students with disabilities who are receiving special education through public school. That has all, just been stopped. This is more than just education in a sense. School can help shield children from the world around them. They are a hub of community resources. They have, libraries and computers. They offer breakfast and lunch. I mean, they provide a lot more than just education. So I think we need to consider all of that and be mindful of, especially of those children who are really going to be struggling as we move forward.
And if I could piggyback off your point as well, Shelby, one area of opportunity for us, clearly, STEM has gone a long way in terms of stressing the importance of science, technology, engineering, and math, and what this will do, not only for the child or student, but also what it could potentially manifest for our economy, whether it's within the areas of technology, healthcare, et cetera. However, an opportunity that we are missing is not, and it's clear and obvious now, we're not focusing enough on the health education. And as a result, we have individuals who are less likely to take ownership of their individual health, less likely to fully grasp even the climate that we're in because they're not understanding the ramifications of poor health. And so one of the things that I think we should start doing more intentionally is elevating the conversation of health and healthcare delivery, and even understanding the healthcare delivery system and health policy to the same level of focus that we are immersed in the area of science, technology, engineering, and math. Science, technology, engineering, and math focus can prepare one to become a clinician, but it doesn't prepare one to understand how important it is to, again, own your health and understand the healthcare and healthcare delivery for what it is, and the difference that one could make by just focusing and owning, again, their own health in that particular area. So certainly an opportunity for us to drill down on and be more intentional subsequent to, or as we're looking at this challenge in our proverbial rearview mirror, if you would.
Oh, that was beautifully put. It's so important that we have this comprehensive and holistic view of health. Not only how do we provide healthcare, kind of that reactive treatment, but how do we as, a community look at the system as a whole and understand the inner workings and how each point, feeds into the other. So really great insight there. So I want to switch gears a little bit and kind of focus on a topic that, affects everyone of all ages, all demographics, and that is food insecurity. And I know that and within our own organization, we've been doing a lot of work with our partners to research and address some of the food insecurity within Albany County and other local counties. Just in Albany alone, there's 12% of adults that are reporting food insecurity, and one, that is not an isolated situation, and two, I'm pretty sure that's an underreporting. So, what is, something that we can do about this in the midst of, some of those services having to adjust to the, COVID impacts?
Yeah, I've been quite pleased with the attention that food insecurity has been getting both before COVID and now in the capital region. We've really seen a lot of organizations stepping up. But as you mentioned, we're still far from being food secure. We still see 45% of children in Schenectady County getting lunches from school for free. So it's also a concern, in the elderly and rural populations. So this is definitely still an area of concern. And there were some good interventions that were starting to take place here, and COVID now just has kind of disrupted all of that. So obviously that is going to, in and of itself, is going to cause some problems. Also, when people started panic buying, shelves got low, and low stock shelves don't affect us all equally. I mean, they're annoying for us all, but they really don't affect us equally, because low income individuals, they can't afford to buy in bulk. They don't have a supply at home. WIC participants, they can only buy certain things. So if those things aren't there, they have to go without. Also, fresh foods spoil faster. We want to talk about quality of food, not just getting food to people, and so fresh foods, they spoil faster. So it's a lot harder to eat healthier while also limiting the amount of times that you go to the grocery store. And especially if you're at risk for COVID. And also, this healthier food is expensive. And so what we're going to see is a lot of people supplementing their depleting budgets with unhealthier options. And I do think that we are going to also start to see more people becoming food insecure as a result of the economic effects that we had talked about. This is undoubtedly going to put a strain on our food banks.
Another opportunity is to really begin to rethink obesity. The false construct is obesity translates into being well fed. You have individuals who are obese who are not well nourished, and as a result of their lack of being well nourished, this is why we're seeing prevalence of diabetes, heart disease, etc. So you really have to rethink that. Again, getting back to how we educate about health at the earliest point of intervention in schools, moreover, as far upstream as we can possibly go. The other point I wanted to bring forward, and it's a true success story, when we start looking at diabetes and food insecurities and not having access to appropriate foods, and how these things lead to an overwhelming prevalence of complications associated with diabetes. Geisinger, several years ago, actually developed what was called a food pharmacy, and they were able to basically show how, by providing not only the food but the transportation and access to those foods, they could reduce their costs within their healthcare system profoundly. And so again, this is an opportunity for us to start thinking, differently about not only the impact in terms of what that access to quality foods is going to mean for the individual, but ultimately downstream and upstream, what it could mean for our hospitals and health systems and providers who are overwhelmed and burned out. If we could, again, heighten the level of education when and where it matters most from the standpoint of food and the importance of appropriate food, it could go a very long way. Again, an opportunity to mitigate, investing now at the upstream level before we start seeing those catastrophic events that occurred downstream.
Oh yeah, I completely agree. And I think, pre-COVID, we were seeing many community members. I mean, it's definitely not all, but there was a tremendous effort to, make food a referral. This is an underlying issue that, affects every aspect of your life if you aren't well nourished and have, a consistent and reliable access to healthy food. So there are many services in the community, whether it be through providers or hospitals, that were setting up these food pharmacies or medically tailored meals and getting these individuals connected to the nutrition that they needed. And many times this wasn't just about food supply, this was also about that education piece. How do you help someone that doesn't know how to properly manage their condition, or just needs help getting the supplies to do so? So I'm really hoping that we do see, many of these organizations are still continuing with the food supply things. And because that education piece was in person, some of that has shut down. But I'm hoping that as we kind of start, getting a handle on the situation and adjusting, we can start utilizing those technologies like telemedicine to incorporate those education pieces back into the future. So hopefully we've got some promising, ventures forward with that. So I want to jump gears a little bit again and talk about something that is, it's on everyone's mind, is racial disparities. This is a lot of attention by politicians. Multiple news broadcasts have, had specials on it. And, is this just a trend, or is something is going on here in the wake of all of this?
Yeah, so this is a lot to unpack here. This really is a topic that we have been seeing pick up some steam lately, and rightfully so, because these numbers really are frightening. In Louisiana, for example, 70% of COVID deaths are Black, and they only make up about 33% of the state's population. So that's an incredible difference. In Milwaukee, for example, 81% of deaths are Black when they only make up 26% of the population. We see these numbers, see similar numbers in New York City and all over the country. Actually, an analysis that was just put out yesterday by the Commonwealth Fund compared county case and mortality rates by county demographics. Found that all over the U.S., counties with more Black individuals have more cases, and what's even scarier is a far higher mortality rate. The CDC also just released its national data and found that 68% of cases have no specified race. So we don't even know what their race is. So this information that we're seeing is just from the places that are reporting race. And it's likely to be even higher. There is no requirement to collect or report this information, which makes it very hard to monitor. And this isn't the first time that we've seen this. During the H1 outbreak again, the analysis shows us that there were major gaps in complications and hospitalization rates for Blacks and Hispanics compared to white individuals all across the country. If you want to get into why this is happening, I think that there really are three major reasons. The pre-existing conditions is definitely one of them. Black individuals are more likely to have chronic disease. They have a higher rate of almost every chronic disease in the United States. In Albany County, Black individuals had nearly double the mortality rate as white individuals for diabetes, for example. Asthma hospitalization rate for Black individuals in the capital region was 26.7, whereas it was only 7.2 for white individuals. And similarly for COPD, which is especially relevant to COVID, Black individuals had nearly double the rate of hospitalizations. So these are trends that we see all the time all over the country. One of the contributing reasons to this is definitely pollution. This has been a struggle that we've seen in Albany County by the train tracks. If you look at a map of the United States and you look at where high rates of pollution are, you will see that pollution surrounds the majority Black communities all across the country, with the exception of 4 states in DC. But everywhere else, you see these pockets, including here in New York. And with all these recent studies linking COVID deaths to pollution, it would be no surprise that this is definitely a contributing factor for why we're seeing such high COVID mortality in Black individuals as well. I think the second biggest reason why I think we're seeing this sort of trend has to do with hospital resources and capacity. In these neighborhoods, they tend to have hospitals which have been shown to provide a lower quality of care. They face shortages of PPE, staff, and ventilators, and this was all prior to this. I think the third biggest reason why we're seeing this has to do with implicit bias within the healthcare system. Our implicit biases, they don't leave when we go to work. A recent study by Boston University looked at national claims data, and they found that despite the law that requires ambulances to take individuals to the nearest emergency room, they found that 40% were not doing so. And of course, this is no surprise that these were Black and Hispanic individuals. Another algorithm that is widely used by healthcare systems significantly underestimated the needs of the most chronically ill Black patients. And this is specifically in regards to pain medicine administration as well. I think there could be another reason for the discrepancy that we're seeing besides implicit bias, but I think regardless of the reason, these are the outcomes, and this is what's happening, and they're contributing to Black individuals having worse health and a shorter lifespan. And just lastly here, I want to reiterate that this is not a natural phenomenon. Genetics don't explain this, because we don't see these high rates in other countries. We don't see this massive discrepancy. This really is unique to the United States. And also, blaming this on health behaviors, I think would also be an injustice, because we know that health behaviors are shaped by our environment, our education, and our access to resources.
Great points, Shelby. I commend you for your courage of leadership. And I'd be remiss if I didn't say again, thank you for the opportunity. But to piggyback off several points, the seeds of healthcare inequity were planted generations ago. And basically what we're seeing now, if we were really to be honest about this, I believe in my mind, if you look at the data that is both compelling, robust, and shocking as it pertains to healthcare inequity, that in and of itself is very much a pandemic. So we have a pandemic on top of a pandemic, and essentially COVID-19 is exacerbating these, underlying conditions, and vice versa. The underlying conditions are exacerbating COVID-19. And so really what we're seeing here is a snapshot of what happens when one takes on a sense of gradualism when approaching the issue of healthcare inequity and healthcare disparity. So it's very, very complex. It's not something that we can look at lightly. And as we've focused on and set the tone for this morning's conversation, we have to maintain a forwardly focused perspective on this. There is enough blame to go around. We have two options. We can take time, waste time to point the finger at who did what to whom when, or we can redirect that focus to what can we do today to change future outcomes. So this is a very sensitive, very challenging opportunity, but unless we muster the courage to embrace and look at this opportunity for what it is today, history will assuredly repeat itself. So I just wanted to, piggyback off your points, which were solid, and I greatly appreciate them. And I'm sure our listeners and those that are watching are picking up on this too. But at the end of the day, it's going to fall back on our laps as individuals, what we can do from the standpoint of owning our health and what each of us can do within our respective industries to change the future trajectory of healthcare inequity, which again, if we don't change our behavior, if we stay in the rut of status quo, we won't see any changes the next time this happens, and it will happen again.
Absolutely. So I guess that this, begs the question of what is next? What can we do to address this all? And before we, switch over to the chat and dive into those kind of questions, I really want to hear from you both about what do you think is next for health inequity during this crisis and, inevitably, like you're saying, for the next one.
I think that this is an opportunity to address social determinants of health while also preventing future inequity in health outcomes due to this crisis. Positive changes that we implement now are likely to carry over into the future. And systems that we build with pandemics in mind, they also work for chronic disease prevention and well-being. I mean, these are the same sort of tactics that we need to apply throughout all of healthcare. Some of the biggest things right now, focusing on targeted communication with multiple different touch points and techniques, sharing social support services, education, and mental health resources, really understanding your community, getting engaged within that community with local partnerships and alliances. You can use community-based organizations to help out, even with COVID surveillance and monitoring, to help give targeted outreach. I also think that the use of community health workers can be extremely beneficial this time. I mean, they know their community, they know how to help, and they really can really engage people that we normally have a hard time engaging. And I think with race specifically, there's definitely a few things that need to happen. So first, we need to recognize and address implicit bias. And I see here, in the chat, a lot of people mentioning this isn't new. And I completely agree with you. This is not a new phenomenon. But I am pleased to see that people are paying attention to it right now. And I think that we can use that momentum to push forward. And I think one of the biggest things that hospital organizations and healthcare organizations can do is start using equity tools. First we have to recognize that this implicit bias exists within the healthcare system, and then we have to think about how can we fix it. So using equity tools to make sure that everything that we're doing, we're thinking about equity in mind. And the next biggest thing we need to do is get on data collection and monitoring with racial and ethnic demographics. We need to know this information so that way we can monitor it and get our community health workers out there especially to those communities that are struggling. So I think those are some of the actionable steps we can do right now. But I do think that the most important thing, in my mind right now, really has to be just getting an understanding. I know I know a lot of us here in this call, we get it, and it seems like it's been around forever. Why doesn't everybody get it? But at the same time, a lot of people don't understand. We still have doctors who are not on board with social determinants of health. They don't think it's a healthcare thing. So I think that it's very hard to address something that people are not acknowledging exists. So I think the biggest thing that we really need to do is start this conversation. And I'm happy to see so many people on this call from different areas, because we really do need to break out of these silos, start talking with people about health equity, and understand that these issues existed well before COVID, but we can begin to mitigate them now. We can do this through awareness and early interventions. And really, I just think everything that we do, every initiative that we plan in the public health sphere or in healthcare, we just need to be thinking about health equity and have that on the forefront of our minds and think, okay, is what I'm doing equitable, and how can I make it more equitable or help mitigate some of those effects?
Great points, Shelby. I agree with you across the board on each and every one. And just to further that discussion, again, enough cannot be said about education. Education is fundamental to social determinants of health, and it also happens to be one of our greatest opportunities to close the gap on inequity, as well as literacy and numeracy, which impacts one's ability to navigate and manage their health, notwithstanding, managing population health. And again, back to the point of mitigating, what more can be done? We have got some really interesting and compelling solutions that exist in healthcare today, ranging from lifestyle medicine, which provides an opportunity for an individual to literally turn around, for example, diabetes that might have been diagnosed at the earlier stage. And this goes on to other chronic diseases such as heart disease, and even some cancers ultimately could be impacted in a big way through lifestyle medicine. And the other point that Shelby had brought up is the importance of actionable data. Yes, we've had this conversation before, but what's different now is we have to now take action and start utilizing solutions that can begin to move the needle. Will every decision made, will every solution brought forward be perfect? No, but we cannot forego the good because of the perfect. We have to start somewhere and begin to really whittle away at the challenges that we're faced with. Artificial intelligence presents an incredible opportunity for us to begin to mitigate systemic and inadvertent implicit bias. Artificial intelligence provides an opportunity to utilize quantitative, objective data within the healthcare sphere, and what one can do with that is overwhelming in terms of its impact and for change. Moving on, you have other opportunities that exist through personalized medicine, personalized digital physical exam, which I mentioned earlier on, which allows the physician to rethink how they're going at that patient physical exam, if you would, having an opportunity to mitigate and allow the biomarkers to speak when the patient can't speak to what's ailing them. Again, tremendous opportunity there. So the opportunities are there, but again, I think we should be leaning into, in my mind, those solutions that have an action linked to them. And with that, I think we can begin to move the needle in a meaningful way as it pertains to addressing the challenges and opportunities of healthcare inequity.
Yeah, absolutely. Thank you both so much really important and powerful discussion that we're having here. So I want to focus our last 10 minutes on the chat and make sure that we get to as many of these questions as possible, because I know there's a lot going on the side here. So I'm going to just start at the top. John Shaw had said that hospitalizations, ventilator use, and death rates are 2 to 3 times higher than for others. And this was back a while ago, so I'm not totally sure who he was talking about, but we focus efforts to reducing impact in the vulnerable communities, and we relieve demand for scarce hospital resources and reduce overall death rates, so thereby reducing anxiety for all of us. And his question was, how do we get policymakers to recognize and invest in addressing this?
Well, that's a tough question. I'll begin to answer that one, and I'll allow Shelby to further. That is one of our greatest challenges. I'm brought back to some of my own personal experience when volunteering within the Greater Capital Region several years ago with the Leukemia Lymphoma Society, and having opportunity to speak with various elected officials. And again, this is not pointing the finger, it's just observing. And one of the things that I had observed, there was not an overwhelming knowledge base of what healthcare is. Health and healthcare are different, just as healthcare, and healthcare delivery are different. And what impacts each of those individually and collectively, there's a whole lot of information there. So at the end of the day, from a policy standpoint, I think that it's incumbent upon elected officials to, be more truthful about what they do know and don't know, and take ownership in educating themselves. There have been policy decisions made that have essentially led to the very inequities that we're seeing today. The Patient Protection and Affordable Care Act, which again, not perfect, but a very good start, created an opportunity for us to begin to quell what we were seeing in the standpoint of healthcare inequity. But then when we have a change of administration and they begin to take funding away from that was geared toward or earmarked towards supporting individuals to move through getting their insurance online and utilizing technology, when you take away those funds, you're basically exacerbating the challenge of the digital divide. So it really has to get down to, in my mind, of each of us. Regardless of our political leanings, we have to get to the point where we can set that aside, because there's something far greater, and that's humanity. And if we're not leaning into a solution based upon the benefits of overall humanity within the United States, we are missing an incredible opportunity. And as important, sadly to say, we're revealing our true nature. And we have to get beyond that. It's time to evolve and to grow. So I'll pause there and let Shelby chime in and share her perspective as well, as I see we are coming to the end of our time. So,
for me, I think I'm taking a little bit different of an approach, and I am just really trying to educate the healthcare field to begin with in public health, but also one of the things that I've been doing is really working with a lot of some of the larger nonprofits like the American Cancer Society, the U.S. Pain Foundation, organizations that already have those sort of advocacy connections with policymakers. And I'm just getting those organizations to get on the same page, to realize that this is a problem. And so I'm kind of taking like the behind the scenes approach of just getting everyone else to recognize it and on board. And because I think it's hard for a policy maker to come out and put forth a policy in healthcare and then have half of the healthcare industry be like, what are you talking about? So as much as I do think, advocacy is important, that's kind of the way that I've been doing it, through people that kind of already have those sort of connections, and just making sure that they're aware of really of what's going on.
Great. So we have another question here from Sharon Thomas, who was echoing back to the disparities discussion that we were having, and she was saying how now that we're seeing these numbers and everyone is aware, how do we ensure that race and ethnicity is collected and we don't hear wow again, because it isn't new news.
I think that's probably a question for county health departments.
Yes, that's an important and very significant question. At the end of the day, that's data that our hospitals and health systems capture, and then as it trickles down at the public health level, it's a decision that's made to capture that data. That's low hanging fruit. Let's be honest. Um, it's just a matter of making a decision to do it. Take advantage of the EMR systems that are out there and other health information technologies, and just get the data into our system so we can begin to measure it. Quite frankly, I don't think we're seeing the full snapshot of the data that speaks to inequities. But again, an opportunity for us to work on.
Yes, absolutely. So there's a lot of great discussion happening in the chat, a lot of resource sharing and back and forth. So if you have any other questions, please write them in. We have 5 minutes left. We can get to those. We do have another question, though, from Michael Johnson, who wanted to know what the qualifications of a community health worker are and if there's an opportunity for residents to become a CHW. This is a particular area that HCDI, and I know we have Simone Brooks in the chat with Benny, but we do a lot of work with community health workers. So if Shelby, you want to jump in and kind of tell them a little bit more about community health workers?
Yeah, so community health workers are a really invaluable tool. So basically, they are members of the community, and then they're trusted community members, and then they are trained in some basic health foundations, some basic health coaching, how to talk to these individuals. They get some training on that sort of thing, and then what they do is really help connect individuals in the community with community resources. So there's so many, nonprofits and services out there, but trying to understand them all and figuring them out all yourself, like that's really overwhelming. So this is where community health workers come in. They know the services, they know how DSS works, they know how to get insurance, they know all of these things, and they can really help an individual, help them way quicker than they would be able to do themselves. And some have a health coaching component to them, where they can help reduce chronic disease rates. And we've seen there's been a few different studies that have shown how when you have a community health worker who knows how to help manage diabetes, for instance, you can see the effect that this has on the people that they're helping. Their A1C levels are going down, just because they're able to help them get nutritious food, but also help them with that education side of things. And they're really just a support system for individuals in the community who need it the most. And we've seen HCDI has a few navigators who do similar roles, and we're always hearing stories of people who are saying to us, how beneficial the work that we did was for them. So I think that they are such an invaluable tool, and I think we're going to start to see them used a lot more. And I think they should be.
Absolutely. So we have Annette in the chat who's wondering if we'd be doing any more of these webinars. We don't have anything planned right now, but hopefully. And she also wanted to know more about the use of artificial intelligence, the use of equity tools, and additional ways to influence change. So we're going to be sharing Shelby and John's contact information at the end of this, and also in a follow-up email. So that would definitely, the artificial intelligence component is definitely up John's alley, so we can share more information about that. So I think we are out of time though, so if I didn't get to your question, I'm very sorry, but I'm really happy to see that the chat was really interactive, and everybody was sharing resources and having discussion. If there's any last closing pieces, Shelby or John, that you want to jump in on?
I have one final point I want to make, and it gets back to the economics piece and economics conversation. There's evidence that shows quite clearly addressing social determinants of health represents a $1.7 trillion opportunity to reduce or slash spending. And our overall U.S. budget for healthcare is approximately $3.5 trillion. So you can see there's a tremendous opportunity for us to rethink how we're allocating funding, lean in a little bit more assertively in the area of addressing social determinants of health and going further upstream intentionally. With that, where we have greater control over economic elasticity and cost, price, et cetera, this creates an incredible opportunity for us. So I just wanted to leave with that. And again, just to thank you all for the opportunity. This has been a wonderful experience.
Thank you so much.
Yeah, I just wanted to thank everyone again. I know that this, someone mentioned, are we preaching to the choir? And I guess in some sense we are, but, I think that it still is very important. I do see, there were people on the call who I don't typically see in these conversations. So I think every opportunity that we have, if we can just bring a few more people in, I think it really is invaluable. And I love the idea of, going to our senators and everything. I would love to, but at the same time, if the people aren't behind it, it's not going to matter that much. So I want to thank everybody for coming and being involved in this incredibly important conversation.
Absolutely. Well, thank you, everybody. Thank you, Shelby and John, for coming out, and everybody that took the time to participate. We do hope to do something similar again. We'll keep you all posted, so keep an eye out for that. And also for the HCDI economic and chronic disease report. We are hoping to get that out in a timely manner. So thank you all again, and I wish you all the best. Stay safe.
Bye, everyone.
Take care.